So now we will move on to the main presentation by Dr. JB on the subject of panuveitis. Over to you, JB.
At the outset, I'm really so grateful for getting the opportunity to by the EIZOC on this ORTS, and I like to thank Professor B.N.R. Subodhi, Dr. Ajit Babu, my good friend, Dr. Satyajit Sinha, Dr. Vibhuti Kashyap, and I feel always that the teacher learns the most. Just sharing the knowledge, it gets magnified, it expanded. So what I am going to do is not to teach you, just to share my experience. And what I made it is a very great basic level at the postgraduate level, and very simple few cases. And I'm not going to details. I'll take up the questions later on. Let me share my screen. Hopefully it will work. Is my screen visible?
Yeah, yes.
I'm audible?
Yeah,
yes, sir.
Yeah. So what I want to do is that talk about panuveitis, clinical feature, differential diagnosis, and approach to management. It's not a theoretical one. What I have done in some of the sitting in my clinic, I'll be sharing that. So to start on the basic, the uveitis IUSG International Uveitis Study Group that I'm a member of that group. They have divided uveitis into 4 morphologic pattern: anterior, intermediate, posterior, and panuveitis. You know all. When we do have all the layers of the middle coat of the eye is involved, that's called panuveitis. And this has been done by the standardization, the uveitis nomenclature group, 2005. It's further consolidated that we should call anterior uveitis, not iritis or iridocyclitis or cyclitis, or retinitis or coronary. We will call it posterior uveitis, anterior uveitis, intermediate uveitis, and panuveitis when there is all the coats of the uveal tract is involved. So what is the panuveitis patients present? They are not like patients presenting with the photophobia that much. They present with a gross reduction in the vision. So there is a gross reduction in vision in a few days or a week time. There might be a pain, there may be blurring of vision, there may be floaters, there may be mild photophobia and the redness. The most important thing is that they rob away the vision very fast. So I'll show the few examples of panuveitis. Sympathetic ophthalmia. When I talk about sympathetic ophthalmia, I remember of a patient whom I see 20 years ago. This was a 12-year-old boy from Bihar, had bow and arrow injury in the left eye. And this patient lost the vision in the left eye, but after 1 month, he started showing blurring of vision in the right eye. He showed to the local ophthalmologist, and the local ophthalmologist, of course, treated with the steroid, but he was not getting better. So grandfather got worried, and he brought the patient to Chennai, Madras that time. And when I looked at the fundus, I found the disc margin is blurred. There was a secondary retinal detachment, and that time that immunosuppressive agent was not in vogue that much 20 years before, but I started using it with my experience at stint at Los Angeles, USA, under Dr. Narsingh Rao. I thought that immunosuppressive agents would be can be added because the patient has already had a steroid. So this was a very initial patient of mine. I treated with azathioprine, a 50 milligram tablet, half tablet 3 times daily, and put the patient in addition oral steroid. patient got back 6/6 vision in the sympathizing eye, which is quite gratifying. But that is not the end of the story. The patient contacted me through Facebook and told 20 years after we lost contact, he said that he is doing postdoctoral fellowship in Finland and he wanted to collaborate with me in the research in genetics. So it was one of the wonderful email which I got from in my life, that one of the boy which I've treated in the 20 years back has become a postdoctoral fellow. So this was one of my initial patient of sympathetic ophthalmia. What is sympathetic ophthalmia? It's a rare bilateral granulomatous panuveitis. There are two eyes. One is the exciting eye, which you call injured eye, following surgical or accidental trauma to the eye. Mostly is a penetrating ocular trauma. And sympathizing eye, this is the uninjured eye developing uveitis after a latent period. So eye is such a wonderful organ, such a peculiar organ, that one eye got injured, other eye has got sympathetic ophthalmia. It doesn't happen with the ear, but it happens with the eye. And there are famous, the Louis Braille, who lost the vision, was due to the sympathetic ophthalmia. There are very famous people lost vision due to the sympathetic ophthalmia. This is one of the vision-threatening panuveitis. So nowadays, what has happened, that there are maybe many causes of sympathetic ophthalmia. Even cyclocryotherapy can produce sympathetic ophthalmia in the other eye, which I have reported one case. Pars plana vitrectomy has emerged as an important cause of sympathetic ophthalmia. So sympathetic ophthalmia risk following vitrectomy is more than twice the risk of infectious endophthalmitis. So this is one of the small gauge vitrectomy which has started, and it has found to be one of the important reason which you should not ignore. Particularly multiple vitreoretinal surgery, when the patient undergoes, they can have an loss of vision due to sympathetic ophthalmia. Early examinations, early identification, if we see the vitreous cells in the other eye, you should have a careful examination. Even a OCT, SSOCT can be done, or ultrasound can be done to see that the patient is having sympathetic ophthalmia or not. So we described the multimodal imaging in sympathetic ophthalmia. As I mentioned to you, that in tubercular choroiditis or any posterior uveitis, fundus autofluorescence is now emerged as one of the simple tool to identify the status of the lesion. Then we come fundus fluorescent angiogram, indocyanine green angiogram, optical coherence tomography, and ultrasound B scan. In sympathetic ophthalmia, I will first put that ultrasound B scan. Ultrasound B scan will show the diffuse choroidal thickening, mostly in the posterior part. That would be my first investigation in sympathetic ophthalmia. So for the sake of convenience, I put in the order of fundus autofluorescence, fluorescent angiogram, indocyanine green angiogram, optical coherence tomography, and ultrasound B scan. If I don't have any of the, I will do an ultrasound B scan to see the choroidal thickening. So what we see in fundus autofluorescence in sympathetic ophthalmia, hyperautofluorescence in exudative RD, and speckled area of hyper and hypoautofluorescence resemble leopard spots in resolving exudative retinal detachment. It's not very typical of sympathetic ophthalmia. Any exudative retinal detachment in resolving phase, you can see the speckled area of hyper and hypoautofluorescence. You see the similar thing in VKH. This is the active disease, and you can see that, I don't know whether my cursor is seeing that one. You can see that hyper and hypoautofluorescence. And if it's a healed stage, you will see the hypoautofluorescence. So now we're coming to the fluorescent angiogram. Fluorescent angiogram can be very effective. After the ultrasonography, I would prefer to do a fluorescent angiogram. So it will show pinpoint leak with late pulling of the dye in the like VKH, placoid early block with late stain like APMPP, and disc vessel leakage with staining. And this will be the acute stage. You can get, I'll show a picture soon. Chronic stage, you get the nummular transmission defect, nummular scar, like, and that Dahlen-Fuchs nodule, a gradual hyperfluorescence with staining, subretinal fibrosis. And one should not forget that the patient can develop CNVM, choroidal neovascular membrane, which can be picked up by fluorescent angiogram quite well. So choroidal neovascular membrane is often occurs peripapillary area in VKH and sympathetic ophthalmia. So you should be distinguished from disc edema or papillitis from CNVM, which might be hidden in a case of sympathetic ophthalmia. So here is a very classic example of sympathetic ophthalmia with the sympathizing eye. And you can see the point leaks there, and in the second frame, and there is a pulling of the dye in the subretinal space and showing the bullous pockets of subretinal fluid, hyperfluorescence. So indocyanine green angiogram can be helpful. Multiple hypocyanosin spots is seen, cellular infiltration, Dahlen-Fuchs nodule, overlying edema, helps in the staging of sympathetic ophthalmia, fading in the late phase active lesion, persisting in the late phase chorioretinal atrophy. But I would favor getting a fundus photograph or fundus fluorescent angiogram and ultrasound. And here is the FFA showing the initial point leak and with the pulling of the dye in the late phase, lower frames showing that multiple hypocyanosin spots and which fades away in the late phase of the disease. So as I mentioned to you, ultrasound will be my first weapon to reveal the choroidal thickening, medium to large serous retinal detachment. Even a subtle serous retinal detachment can be picked up by ultrasound. And you can compare axial length of the exciting eye and sympathizing eye. If the axial length of the exciting eye is good, there is a still chance of getting back some vision. So we have described the choroidal structural changes in sympathetic ophthalmia and swept source optical coherence tomography. Optical coherence tomography has become an important component of identifying sympathetic ophthalmia or VKA. So what it does show, it shows bacillary layer retinal detachment, multiple serous neurosensory detachment, and then hyper-reflective safety. You can see the micro hyper-reflective safety, dividing detachment into pockets distinctly, and choroidal thickening. Swept society can be used for the choroidal to detect the choroidal thickening. So choroidal thickening can occur also in case of central serous chorioretinopathy, but you won't see the subretinal safety which you see in case of VKH or sympathetic ophthalmia. Subretinal choroidal folds or choroidal striae can be seen, loss of physiological choroidal vascular pattern. And then Dahlen-Fuchs nodule, which is classically described in sympathetic ophthalmia, small, irregular, hyper-reflective areas under the pigment epithelial detachments and disruption of overlying RPE. Extension of this hyper-reflective presumed inflammatory material into the outer retina is seen. So Dahlen-Fuchs nodule can be easily seen and identified in sympathetic ophthalmia. And these are the nodules which are seen in the periphery in this case, and which is very typical of VKH and sympathetic ophthalmia, particularly sympathetic ophthalmia. We have got a very nice, I just have got a very nice picture from my path lab that Dahlen-Fuchs nodule. You can see that arrow showing one of the Dahlen-Fuchs nodule. There is a retinal pigment epithelial atrophy, and underneath the retinal pigment epithelium, you can see the collection of inflammatory cells in the form of lymphocytes and epithelioid cells. And the what happens is also the choriocapillaries remain spared. They are not closed, as we've seen in case of VKH, whereas in the late stage,
Hello.
the choriocapillaries occlusions is seen.
Hello.
So, anything?
No. You can continue, JB.
Yeah.
Someone else.
How do I treat a case of sympathetic ophthalmia? My way of treating is the intravenous methylprednisolone. 1 gram daily I give for 3 consecutive days, followed by the high dose of oral steroid. When I do taper the steroid, I do the slow tapering in sympathetic ophthalmia, like not in the case of posterior scleritis or so. So I will do the slow tapering, and over the 6 months of period, and add azathioprine or mycophenolate mofetil. And if not responding, I switch over to the T-cell mediator, T-cell inhibitor, like cyclosporine or calcineurin, that is also called calcineurin inhibitor. This is another case of sympathetic ophthalmia, 7-year-old boy, trauma, right eye with a wooden stick. And this patient had 1 week later, left eye developed sympathetic ophthalmia. You can see the bullous serous retinal detachment, and a visual acuity was hand movement. And I want to show you how the patient has responded to treatment. Surface of OCT showed multiple serous retinal detachment, pockets of serous retinal fluid with subretinal septi. And this patient was treated with azathioprine and steroid. Vision came back to the 6/6 Amazing. The whole retina becomes, which was bullous pockets were there, has come back with the OCT coming, showing to the normal foveal contour. And this is a shifting gear from sympathetic ophthalmia to another disease which closely mimics sympathetic ophthalmia is VKH. Is also another common panuveitis, particularly in Chinese and Japanese population. We see also quite a good amount of VKH. This is a 34-year-old man, or it could have been a woman also. 10 days history of blurring of vision, history of fever, 10 days prior to the onset of symptoms. And this patient was seen by another ophthalmologist and was on 80 milligram oral prednisolone, antechamber quiet, few vitreous cells. Base corrected visual acuity was very poor, 3/60 and 2/60. And fundus fluorescent angiogram, as you have seen in that sympathetic ophthalmia, pinpoint leaks and the pulling of the dye in the late phase. So this is a pinpoint leak in the right eye, and this is the left eye is showing that the point leaks with pulling of the dye, suggestive of VKH or VKH in the bilateral serous retinal detachment. Surface OCT showed a multiple serous retinal detachment, neurosensory detachment with subretinal septi. And ultrasound showed diffuse choroidal thickening, 2.21 millimeter. As you see, that 1.3 should have been normal. So it's almost a double. And patient, how did I treat it? I treated with the IVMP 1 gram per day for 3 days. Vision improved to 6/24 and 3/60. And started on 90 milligram oral prednisolone and tapered weekly by 10 milligram. Reviewed after 8 weeks, vision improved to 6/12 N12. And the posterior pole choroidal thickness, however, remains 605 microns in the right eye and 626 micron in the left eye. So steroids I maintain at 40 milligram till that vision comes back, and tablet azathioprine 50 milligram BD. Surface OCT choroidal thickness was 230 micron in the right eye and 236 micron in the left eye, which is quite normal. Vision came back to the 6/9 in the right eye and 6/7.5 in the left eye. Now the question is how long we put the patients on treatment. As the patient is put on the long-term oral steroid, side effects are more. So I have put the patient on tablet prednisolone 10 milligram per day and tablet azathioprine 50 milligram twice daily for 6 months, and 2 months twice daily for 2 months, and once daily for 6 months. So about 8 to 9 months, I put the patients on treatment, and the patient had improvement of the vision. So what we have discussed is the so far a case of sympathetic ophthalmia and Vogt-Koenige-Harder disease. So Vogt-Koenige-Harder disease is described, I don't want to be theoretical, described by the three ophthalmologists, Vogt, Koenige, and Harder, and this was combined now and is called a one disease called Vogt-Koenige-Harder disease. So there is a granulomatous panuveitis. You can see mutton fat capies, broad posterior synechia, and serous retinal detachment. Both anterior and posterior segment is involved. They initially present with the neurological symptoms, and many of the times they go to the neurologist, and the neurologist first finds the disc edema, and they do an MRI of the brain or CT scan. They thought that it is describing an optic neuritis. So they don't do so they are not able to get the indirect ophthalmoscopy or other methods. So the disc edema is one of the many early features with the neurological symptoms in VKH. So they develop in the very late stage, poliosis, vitiligo, alopecia. These are the dermatological findings, and which you don't see in the active stage of the disease, in the heal stage of the disease. This vitiligo often disappears with the course of time. So what are the common differential diagnoses where you can make a mistake? The top on the list, you should not miss central serous retinopathy or chorioretinopathy because the treatment is diametrically opposite. So if good fundus fluorescence angiogram is necessary in case of VKH, the reason is that I will show you a case. Other conditions like sympathetic ophthalmia, idiopathic panuveitis, posterior scleritis. Posterior scleritis is often unilateral and occurs in the female. Uveal effusion syndrome is closely mimics it, but you won't see the vitreous cells in uveal effusion syndrome. And the size of the globe might be non-ophthalmos or size of the globe is less. So this is a case. This patient presented with a serous retinal detachment, bilateral, and somebody treated with the oral steroid as well as the IV prednisolone. When I did the fluorescent angiogram, we found that there is a serous retinal detachment obviously, but there is a multiple point leaks were there. And this is the typical features of central serous retinopathy in multiple leak CSR with exudative retinal detachment. They can have the similar presentation. So how do you treat it? IV prednisolone, as I mentioned to you, high dose of oral steroid, slow taper, 1 to 1.5 milligram to start with. Immunosuppressive azathioprine, mycophenolate mofetil, cyclosporine. If it is not responding, triple agent immunosuppressive steroid, azathioprine, and cyclosporine is given. Some reports are there today. Some reports are there recent time that treating with the biologic agents like adalimumab, infliximab. I don't have an experience with that. I put the patients on steroid, IV prednisone to start with, and then add immunosuppressive agents with the steroid in slow tapering. So this is my way I treat it. IVMP, high dose of oral steroid, immunomodulator steroid, duration of treatment, minimum duration of 6 months. I don't have experience of biologics treatment with VKH. So you need to, not only you need to treat the patients, you need to look for the complications. That cataract is 42%, glaucoma is 38%, subretinal fibrosis, and then there is a choroidal neovascularization and cystoid macular edema. So one need to take care of the complication. Okay, Dr. Ajit Babu, in case if there is any questions in between, you can stop. It's a little non-formal way I want to talk.
Okay.
So there is a 2021, there's a new classification criteria for early stage VKH has come. This was necessary that because when the classification of VKH was made, that time Swepsos OCT was not there. So nowadays, every ophthalmologist or EV specialist do a Swepsos OCT or EDI OCT in case of sympathetic ophthalmia, and they do a central serous serous retinal detachment with multiple pockets of serous retinal detachment, and safety on optical coherence tomography. So these are the features which has been added to the new classification which has come from the Sun Working Group in American Journal of Ophthalmology 2021. And one need to rule out syphilis as well as sarcoidosis in case of sympathetic Vogt-Koenigi Harder disease. Now coming to the another uveitic entity which is relatively uncommon in our country is Behçet's disease. I must have seen about 150 to 200 cases only, and this is a disease which is a chronic relapsing occlusive vasculitis of unknown etiology, and it's also a pan-uveitis. But what is dangerous in this disease is that the patient gets optic nerve involvement quite fast, occlusive, macular ischemia, and the patient loses significant amount of vision. How do they present? They can present with a cold mobile white hypopyon. So if we see a cold hypopyon, no circumstantial congestion, you should look at the fundus to see that whether there is a vitritis, retinal vasculitis, or optic nerve lesion, papillitis, or optic neuritis. So they can have severe vasculitis, arteritis, and phlebitis, both are there, and they can have vitritis. So these are the ocular features, but they can have that other lesions. You should take the history of oral aphthous ulcer, multiple painful oral ulcer, genital ulcer, erythema nodosum, and dermographism, positive pathogen test. These are the systemic features of Behçet's disease. And here, one test is very useful, is called fundus fluorescent angiogram. It will be top on the list, will be a fundus fluorescent angiogram. What we will find out is the capillary farning as is seen over there. And one can see also that macular area, the cystoid macular edema, one can see the optic hot disc, optic nerve inflammation. So the diagnostic criteria of Behçet's disease, one need to have oral aphthous ulceration. Ocular involvement can be anterior, posterior, or panuveitis or retinal vasculitis. And then FFA is typical of capillary farning. And exclusion criteria, if there is no aphthosis, you should take very careful about labeling as Behçet's disease. So what are the tests has been done? A pathology test and HLA-B51. HLA-B51 nowadays is not that pathognomic, but pathology test you can do a simple test. And the diagnosis is vitritis, optic nerve lesion, as well as vasculitis. So how do you treat? Corticosteroid alone is not good for in these cases and is not effective at all. We need to treat with the immunosuppressive agents, either azathioprine. Actually, cyclosporine works very good. And biologics is the agent of choice in case of Behçet's disease. But unfortunately, many of our people in our country cannot afford biologics, which are quite costly, 6,000 to 8,000 rupees once in 2 weeks injection. So this patient, I saw about 15 to 20 years back when there was no biologics. I treated with a cyclosporine 5 milligram per kilogram of the body weight in 2 divided doses. The patient came from Punjab. This young lady got back vision. You can see that 1 week, 3 months, the patient's vitritis and retinal vasculitis resolved. So now I started using biologic therapy. This is a patient of, again, a case of Behçet's disease, vitritis, optic neuritis, and retinal vasculitis is there. And with that infliximab, there is a magical response. Everything resolved and the patient got back vision. But the problem is that when you stop the biologic agents, they sometimes comes back. So I have talked about sympathetic ophthalmia, Vogt-Koenigi Harder disease, and Behçet's disease. I want to talk about a relatively common disease called sarcoidosis. And sarcoidosis is a non-caseating granulomatous inflammation. So what it does is it produces multiple granulomatous inflammation. Copy nodule, which you have shown in this picture today, can also be present in sarcoidosis. Is more common in sarcoidosis than tuberculosis. Copy nodule or Buschakar nodule, large mutton fat KPs, vitritis, snowball exudates. The intermediate uveitis with snowball exudates, we have recently described in Indian Journal of Ophthalmology, intermediate uveitis due to sarcoidosis. There can be candleworks dripping, tachydibogy, candleworks dripping in the retinal vasculitis, and retinal vasculitis as such can be seen in sarcoid uveitis. Any retinal vasculitis is seen, one should do the workup for sarcoidosis as well as a collagen disorder. So choroidal nodules is another feature of sarcoidosis. Optic nerve granuloma as seen on this case. This patient responded very well with methotrexate and steroid. So what are the laboratory tests which you should do? 4 tests I suggest. One is that 3 blood tests: serum angiotensin converting enzyme, serum lysozyme, serum or urinary calcium, and high resolution CT test. High resolution CT test and Mantoux test. Mantoux will be often negative. High resolution CT test showed bilateral hilar lymphadenopathy, which is called lambda sign. Raised serum ACE, which can be also seen in tuberculosis sometimes. Bronchoalveolar lavage will show the non-caseating granuloma inflammation. Gallium scan we don't do. And if there is an extraocular lymphadenopathy is there, one can do the biopsy and see the non-caseating granuloma. What's new? It's a very simple test has come in the newly to it is the lymphopenia as a predictor of sarcoid uveitis. This has come in the British Journal of Ophthalmology recently, and we have published, we have sent one article for publication with the lymphocyte count and serum angiotensin converting level in sarcoid uveitis. This is the revised criteria of international workshop on ocular sarcoidosis has come in 2019. I don't want to go into the details of it, it's in the small print. But one of the things which I want to highlight is the gonioscopy can be very important. And you can see the trabecular meshwork nodule or tent-shaped nodule. You can see the snowball or pulse of vitreous opacity, optic disc nodules, and specific investigations, negative tuberculin test, raised serum ACE, elevated serum lysozyme, and lymphopenia, which has been added to it. So coming to the infectious panuveitis, which we come every other day we see, and I just give that acronym TV. There are 3 things is there: tuberculosis, toxoplasmosis, treponema, and viral. So starting with the tuberculosis, which is the bugbear, and it can be granulomatous anterior uveitis, broad posterior synechia, retinal vasculitis with choroiditis as seen in this picture, multifocal serpiginoid choroiditis, which has been told by Asmita earlier, and subretinal abscess. There are 2 causes of subretinal abscess. Most common cause in our country is tuberculosis, but nocardia is another cause which can cause subretinal abscess. So choroidal nodules, tuberculum of the choroid, which you call, and it is tubercular uveitis. One should do a Mantoux test, which can be positive sometimes, and particularly necrotic Mantoux is strongly indicated of tuberculosis. Quantiferon TB gold test, but not a single test is diagnostic of TB. Chest X-ray, HSCT thorax, and intraocular fluid test. If there is a strong clinical suspicion is there, and all the tests are negative, you still suspect tuberculosis, you should do an intraocular fluid analysis, either anterior chamber tap, which is commonly done, and where you can get that DNA from the aqueous fluid and amplify it in 10⁶ times and do a what is called polymerase chain reaction. If we do not able to take a diagnosis, I think it would be a good idea in case to refer to a center where we can do the PCR testing to confirm or clinch the diagnosis. Systemic features of TB. This is a case which the patient has atypical presentation, frosted branch angiitis. This is an 11-year-old girl who has got abdominal tuberculosis, and the patient had retinal vasculitis. And this was treated with antitubercular treatment and steroid, and it responded nicely. So coming to that second T is the toxoplasmosis. Toxoplasmosis, I will also start with a case now. This 35-year-old male, HIV positive patient, sudden dimness of vision for a week. And when you look at the picture, you will think that it is a viral retinitis. But it was not a viral retinitis. The patient was found to have HIV positive, and it was the toxoplasma PCR was positive. So atypical panuveitis, you should think of toxoplasma also. Though the toxoplasma can present with the typical focal choroiditis with a headlight in the fog appearance, or a by the side of the scar choroiditis lesion, but toxoplasma can, in immuno suppressed patients or HIV positive patients, they can present as retinitis. Now coming to that last infectious agent is the treponema. So this is a 43-year-old male, dimness of vision and floaters. He was diagnosed as CMV retinitis, and he was given with intravenous ganciclovir. He was HIV positive. I used to shake hands with all my patients. When I call the patients and shake hands, so all male patients. When I shook hand with the patient, I found something wrong in the hand, something rubbing in my hand. And I found there is a rashes in the hand. That made me suspect that the patient is probably having what I found later on in the fundus is a syphilitic retinitis, subretinal precipitates with serous retinal detachment. And that indeed my suspicion was correct. RPR-TPH was positive, and it was a syphilitic retinitis. Treatment with the done with the injection penicillin, and there was a marked resolution of inflammation was seen, and the patient got back vision. So syphilis is a one-time disease, and if you can identify the disease and treat it properly, it can be cured. So although it was an accidental finding, our mind has to be prepared. This is another case, 30-year-old male, and patient presented with a gradual dimness of vision in both eyes for 3 months. When I look at the eye, I found a large exudates in the fundus. It doesn't look like intermediate uveitis or past pronitis, but I couldn't guess the diagnosis. If you can guess the diagnosis, I think you would be a genius. And actually, I couldn't, and it was found out to be syphilis. So any atypical uveitis, you should suspect syphilitic uveitis and do both the treponemal and non-treponemal test. This is a pre-treatment, and this is the post-treatment, so that this is such an amazing recovery is possible in syphilitic retinitis. Serological test for syphilis, both treponemal test like VDRL and non-treponemal test VDRL and treponemal test FTABS or TPHS should be done. Ocular syphilis, as I mentioned, can mimic any type of uveitis. Order both the tests in suspected syphilitic uveitis. So take-home message is the uveitic conditions in syphilis should be considered as differential diagnosis. Serology is the mainstay of diagnosis. CSF analysis should be done, which all syphilis cases should be taken as the neurosyphilis unless proved otherwise. HIV infection has to be ruled out. Response to anti-syphilitic treatment. So coming to that V part of it, 3T I have talked. Now I want to talk about the viral one. Viral one is let's start with the case. This is 34-year-old male. He lost vision in one eye due to the chicken pox. And when you came to the only single eye which was having vitritis and retinitis coming from the periphery as it just approaching like a soldier to the attack, and it's a peripheral wedge-shaped lesion with retinal hemorrhages. So he say here is the diagnosis should be very prompt, rapid, and should we have a strong suspicion. If we have a picture like this, you should not forget second time that you have a case of a viral retinitis. In fact, this patient was on VZB was positive, ACTAP for PCR, for HSV, HZB, CMV was done, and VZB was positive. So acute retinal necrosis is like a wildfire, is a real emergency. We need to treat with the patients very aggressively with intravenous acyclovir, along with the intravitreal ganciclovir sometimes required, and timely barrage laser, which is often debatable whether it helps or not, but one need to be very aggressive in the treatment. So there are few emergency in uveitis, not like retina people or endophthalmitis. That's one of the emergency in uveitis is acute retinal necrosis. So fast diagnosis and management is required. So last is that muscular syndrome. So muscular syndrome in uveitis, you should not miss it. This is a 57-year-old lady. He was seen in one of the Apex Institute in the country. Painless gradual dimness of vision 9 months. He was diagnosed as tubercular choroiditis. For 9 months, he was on anti-tubercular treatment. But if you look at the carefully, this is not any pigmentation was not there. There's a leopard skin-like appearance. So we suspected muscular syndrome, vitreoretinal lymphoma. We went ahead, Dr. Mahesh Shamugam did the fine needle aspiration biopsy, and the fine needle aspiration biopsy showed, you can see that what a large lymphoma cells were seen in the yellow arrow. It was an intraocular lymphoma. And in fact, our suspicion was correct. Diagnosis, MRI brain showed CNS lymphoma 6 months after patient died. But if we had made an early diagnosis and prompt treatment, one can give injection rituximab or injection methotrexate and can salvage the vision as well as the life of the patient for some time. So this is another patient, 51-year-old female, seen at Kolkata, blooding of vision floaters in both eyes, vision 6,6N6 in the right eye normal, left eye few cells. Fundus showed multiple subretinal nodule. Patient had joint pain and husband had pulmonary tuberculosis. So it directed to us as a tubercular choroiditis. We went ahead and ACTAP for PCR for MTV done elsewhere and it was negative. And then we thought that we were dealing with some kind of tumor. Primary intraocular lymphoma was our first diagnosis. We did a vitreous biopsy. It showed inflammatory cells only. But when MYD88 mutation was negative also, but there was a strong suspicion of lymphoma. We went ahead and do a fine needle aspiration biopsy exactly through the lesion. And it showed atypical lymphoid cells as seen in the top picture. And immunohistochemistry showed CD20, that is the B cell marker positive, indicating it's a primary vitreoretinal lymphoma. MRI brain was normal. PET CT no metastasis. Intravitreal injection of rituximab was given. Patient lived for quite a long time, but ultimately succumbed to CNS lymphoma. So lastly, don't miss endogenous endophthalmitis. This patient had history of admission in the hospital with intravenous infusion. And this patient had what he called is a endogenous fungal endophthalmitis, candida endophthalmitis with the contaminated fluid. The last case is a 44-year-old female diagnosed as intermediate uveitis in elsewhere, given posterior subtenon injection, and came with the urinary tract infection. I want to cut the long story short. He is told small, medium-sized keratic precipitate, AC cells, vitreous cells. Diagnosed initially was intermediate uveitis, spillover anterior uveitis. Patient had a disproportionate loss of vision, PLPR inaccurate in the right eye, KPs with fibrin, aqueous fluid 4+, cells 3+, with early synechia. Right eye, there's dense vitreous haze, no fundus view. Ultrasonography showed plenty of low reflective mobile membranous vitreous echo. Retina was attached. Advised to continue oral and topical steroid. And that worsened the situation. CT scan shows lymphadenopathy with apical lobe concentration, infective, sarcoid, neoplastic, all the possibilities were kept. And here I want to highlight the patient was MANTU negative, less than 3 millimeter, which it was not directing us to tuberculosis. Serum AC was elevated, ESR was 61 millimeter, quantiferon TB gold test positive, HLA-B27 positive, negative. So, with re-evaluation of the chest film done, strongly suspicion of TB, advised to review with the physician for ATT. The patient 4 days later presented with the hypopia and intense fibrinous reaction. Started on topical steroid every 15 minutes, planned for IVMP even 1 gram for 3 consecutive days. Then later on, the patient presented with the granuloma, and it looked like endogenous endophthalmitis, fungal infiltrate. Our first diagnosis was fungal endophthalmitis. ACTAP done, PCR was negative for TB, bacteria, fungus. When we took the patient to the OT, we could find out the dense exudates in the vitreous cavity, lensectomy and vitrectomy done. Vitreous sample was sent for evaluation. And what we found in the vitreous is anybody's guess. And you can see that intravitreal vancomycin, cephalosporin, and dexamethasone given, thinking that this is a bacterial endophthalmitis. When he did that acid first stain of the vitreous specimen, we could find out that there was a Gill-Nielsen stain acid first bacilli, that the pink color bacilli was seen. What we thought that fungal endophthalmitis or intermediate uveitis turned out to be a tubercular pan-uveitis, which you should not miss. In our country, this should also always be kept in mind. So hypopia noted, intravitreal amikacin and dexamethasone given, and the patient after the second line ATT was started by the physician, intravitreal amikacin, dexamethasone given. Hypopia is the repeat intravitreal amikacin and dexamethasone was given, and then finally the exudate disappears and the patient got back reasonably good vision. So there are several cases of endogenous tubercular endophthalmitis and panophthalmitis reviewed the case series, and we also added one case in this series. Another important thing is that one should not miss is the panuveitis is the sometimes cystic sarcus, degenerated cystic sarcus can also produce, or toxocara can produce parasitic lesion panuveitis. So there are practical points in panuveitis. One should remember most vision threatening. We need to take a careful history, tuberculosis, fungus, syphilis, immunocompromised status. Ancillary test is important. Laboratory diagnosis can confirm, and what is required in other forms of treatment, uveitis, an aggressive approach. So I think is quite a bit of time. I think we have got some time for questions. I hope I just want to give a panoramic view of panuveitis, non-infectious and infectious.
No, sir.
I once again like to thank you for giving us the opportunity. Let me stop
you gave
sharing.
You gave us extensive causes for this panuveitis. A wonderful presentation, I would say. And you have not left any disease which has not caused panuveitis.